So right now I have the pleasure of introducing Dr. Oksana Sikorsky, who will be speaking on genes and Parkinson's, what we know so far. Dr. Sikorsky is a professor of medicine, neurology, medical genetics, psychiatry, and pediatrics at the Faculty of Medicine and Dentistry, University of Alberta. She was a Tupin Research Chair in Neurology from 2010 to 2020. She received her medical degree from the University of Calgary, following a residency in neurology and a fellowship in neurogenetics at the University of British Columbia. Dr. Sikorsky was recruited to the University of Calgary in 1984 as director of the Movement Disorders Program. From 2005 to 2010, she was the head of the Department of Medical Genetics and the first female department head in the Faculty of Medicine. In 2010, she was recruited to the University of Alberta to expand the movement disorders and neurogenetics programs. She is now the Director of Neurogenetics and Predictive Testing Program in the Department of Medical Genetics. Her research interests include understanding genetic factors related to the development of neurodegenerative disorders and developing new treatments for these disorders. Please join me in welcoming Dr. Oksana Sikorsky.
Thank you, Randy. Do I just put my slides up? I don't see a share
Yes.
screen button.
The shared screen button should be, if you move your mouse, it's at the bottom. It's a green arrow.
Okay, my slides are up, but can you see them?
No, you have to hit the share
No.
button.
Okay.
So I see your beautiful face.
You see me, but I don't see any share screen button. Sorry.
Uh,
Oh, here it is. Okay. Sorry, I
no,
had
it's
it
all
on.
good. Everyone is different. Every one of these
Yeah, the computer, you
things.
have to find the
There we
button.
go.
Okay.
Yeah. Now I can see.
Okay, how's that? Is that working?
If you hit, there we go. Perfect.
Okay.
Perfect.
Well, thank you for inviting me. It's very nice to be speaking to Parkinson, Alberta again, although I really wish we were in person. I mean, I really enjoy seeing everybody and talking to everybody in person. But I understand with distances and weather, sometimes it's easier to do it this way. So it's my pleasure today to tell you about the genetics of Parkinson's disease. And I'm going to start by talking in general a bit about genetics and how we do genetic testing. So what I'm going to do is review the different types, uses, and pros and cons of testing. And then we're going to talk about some specific genes related to Parkinson's disease, as well as to discuss predictive testing, where we tell individuals whether they have inherited the gene for a PD or any adult onset disorder or not. So first of all, I think people realize that children can be born with a variety of genetic problems, and about 5% of children by the age of 5 have a genetic problem that we can identify. But did you know that 67% of older adults have a genetic risk to a disorder, whether it's heart disease or Alzheimer's disease or diabetes or Parkinson's disease? So, in fact, the majority of us as we get older will develop genetic disorders based on the genes that we are born with. So the testing, so what I do now, as well as with my colleagues, I test for a whole variety of disorders that can be hereditary to confirm the diagnosis. Sometimes we can intervene early to help decrease the effects of this problem. We can also tell individuals their prognosis, whether the disorder will move slowly or quickly. And another important thing is that we will stop people, your doctors, from doing unnecessary tests to confirm the diagnosis. However, there is still an issue with availability. I think those that are referred to the genetics clinic do have to wait, on average, 6 months to a year to see us to get the testing done. The cost is still quite expensive, although it is coming down. And genetic testing, for example, we do have exome sequencing ability in Calgary now, so the lab's APL, Alberta Lab Services, is working to bring the cost down and make it more available. There's issues with interpretation, and also genetic counseling is very important as part of it, because if one of you gets a positive test for a genetic disorder, that means likely that other family members are at risk. And so we try to deal with that with genetic counseling. The last thing to remember that if the test is normal, if we run the genetic tests and don't find a genetic cause, it does not mean that it's not genetic. It just means that with current technology, we may not be able to identify the genetic problem. And so currently there are probably, this is an older slide, probably there are about 10,000 diseases now that are, or 10,000 diseases that are identified around the world that have a genetic origin. And but it still takes a number of years to get the diagnosis. So I think, and I think all of us have the same experience where we're seeing to get the right diagnosis sometimes takes a number of years, as well as seeing a number of different physicians and specialists. But with genetic disorders, it even takes longer to get to the right diagnosis sometimes. So let's talk about sort of the practicality of how we approach a patient when we think the disorder can be genetic. First of all, you want to rule out non-genetic causes. And I would suspect that many of you, if you are diagnosed with Parkinson's, will have had an MRI, will have blood tests to look for other things to rule out Parkinson's disease. The next thing we do is we take a family history, a very careful family history, and I'm going to show you a couple of typical pedigrees. We also ask about ethnicity, and the reason for that is that there are some disorders that we know that are much more common in some ethnic groups as in others, which we'll see with some of the genes, and that can help us clarify what genetic testing we should do. And we also ask about consanguinity, about whether there is sort of people that are married to cousins, for example, because that, again, may lead us in a slightly different direction. The other issues that we deal with in genetics, and genetics is becoming much more complex because there is a number of different genes that can cause the same disorder. For example, sorry, I'll talk about genetic heterogeneity first. There's several different genes that can cause the same disorder, such as Parkinson's. Clinical heterogeneity means that the same gene can cause different symptoms sometimes or different problems. So we can't always identify sort of one gene, one disorder. That's much more complex than that. And then incomplete penetrance means that some individuals may have the genetic problem, but don't show any symptoms of the disorder. And that's called incomplete penetrance, as well as variable expression, where one gene can cause different symptoms, even in members of the same family. Okay, so let's talk about inheritance patterns. What kind of inheritance patterns are there? So first of all, is autosomal dominant, which means that if you have a genetic disorder that is dominant, that you exhibit symptoms, and that each of your brothers and sisters and each of your children are at 50% risk for having the same disorder, as well as one of your parents likely had it. Okay. And a good example of that is Huntington's disease. I don't know if some of you may be familiar, because I think Huntington Society is still co-located at the Buchanan Center, is it? And so that disorder is passed on from parent to child, and everybody who has it, their children are at 50% risk of inheriting it. And that's autosomal dominant. Autosomal recessive means that the parents are carriers, so they have one normal gene, one abnormal gene, and it's only when the two abnormal genes come together that the individual has a disorder. And a good example of that is cystic fibrosis. So we know that about 1 in 20 people are carriers of the gene for cystic fibrosis, but they are perfectly healthy. But if they marry and have if two carriers marry and have children, then each of their children is at 25% risk for inheriting the disorder. The next disorder is X-linked. And a good example of this is Duchenne's muscular dystrophy, where it's carried on the X chromosome, and women who have two X chromosomes, so they'll have one abnormal gene, one normal gene, so they're fine. But if they pass on the abnormal gene to a boy who only has one X chromosome because they also have a Y, they have an X and a Y, then that means then the boys will have it, but moms are carriers. Okay, I hope that's clear. We won't talk, mitochondrial is a disorder in the mitochondria, but I don't think for Parkinson's, we don't have any mitochondrial diseases right now. Okay, so this is what a typical family history looks like. And you can see that the little white, so first of all, males are squares and females are circles in all our pedigrees, okay, all in all family histories. And in this pedigree means that the girl on the left side that is not colored in is affected with a disorder. And everybody that's colored in, that's black, is normal, doesn't have the disorder. So in this disorder, we could think that this could be a recessive disorder, so that that the girl on the left has, I don't know, can you see my cursor? Can you see that? The little arrow? Oh, okay. So the girl here has the disorder, but has a brother and a sister that's not affected. And then this woman is married to somebody who, and they have a child with the same disorder. So we would, or the genetic testing could show that, um, and that both of these are carriers, and this child inherited both abnormal genes. So that means that this is a recessive disorder. So this is just one example of how we take a family history and we work out what the most likely pattern is. And then with genetic testing, we can show if that's correct. Okay, this is a dominant disorder. So here, the people in red are affected and the people in blue are unaffected. So you can see here that this male is affected. And then, so he has 3 children that are affected, but a bunch of children that aren't affected. And then each person who is affected can have several children that are affected. So this is the 50% inheritance where it's passed on from parents to child. So this is a dominant disorder. Okay. And Brandy, if there are any questions, you can sort of, if any questions come in on the chat, if there isn't something that's not clear, I'm happy to answer them as we go along.
Perfect. I will do that.
Okay. Now, a lot of times we'll find that the family history is negative. We'll get a person come in and they have no family history. So one of the reasons is that people die before they develop symptoms of something like Parkinson's disease, right? So they may have died before they could show symptoms. So that's, it may be misdiagnosed, or the diagnosis is just not shared with the family. And in Parkinson's, what we find is that when people have a tremor, it can be actually misdiagnosed as Parkinson's when it's a benign tremor. So that's one thing that we do see, and that's one of the things that we have to try to sort out. If a relative has a tremor, is it really Parkinson's disease or not? And a lot of times, in fact, it's not Parkinson's. If people are adopted, or sometimes we don't have the father that we think we do. So sometimes the family history may be incorrect, and that's called non-paternity. The last reason, which I'll come to, is that the disorder is actually a new problem that has arisen in that individual. So sometimes we see a change in the DNA that occurs in the individual and it's not present in the parents. And so it's a new problem that's arisen due to a change in the DNA. But once it occurs, it is passed down, it is transmitted to further generations.
Dr.
Okay.
Suchowersky,
Yes.
sorry, I think this kind of fits in there. The question is, can it like skip generations, like be gone for a while and then show up way later, or is it pretty tight?
Yes. So in some disorders, it can. So for example, if there's non-penetrance, So sometimes people can carry the gene but not show the symptoms. So that's called non-penetrance. And the other situation is where it's a recessive, right? So if it's a recessive, unless you marry somebody else who or have children with somebody else who carries the same gene in a recessive form, then it will be, you won't see it until maybe several generations down. But there's a number of different ways you can see that. So it depends on the gene. It depends
Okay,
on the specific gene.
thank you.
Okay. So we all have 23 pairs of chromosomes, and here's the karyotype that you can see. And what I used to do when I was a medical student, what we used to do is how we used to test for genetic problems is we used to take a sample of blood, grow up the cells, cut out these little chromosomes and paste them together to see if there was anything missing. So this is what we used to do a long time ago. What we do now is automated, and it's called comparative genomic hybridization, or CGH. And what happens there is the DNA is cut up into little pieces, and there's a machine that looks to see whether there's parts of the genes, some of the genes that are missing or duplicated, or you're just missing pieces of DNA. And this is a test that we do, for example, in autism. So we know in children with autism, one of the reasons they can have autism is that some of the genes are either missing or duplicated. And so this is a standard test pretty much in pediatrics now. The next step is to sequence. So we actually look at the individual letters that make up the DNA. So there's 4 letters, A, C, G, and T, that stand for the 4 little compounds that make up DNA. And sequencing means that we actually read the DNA or the GNA itself. And so that's what we do now with most of our testing, where we actually sequence the gene so we can see whether there's an individual letter missing, or extra, or is changed. And then what we're going to is called next-gen sequencing, which you may have heard of, which is exome sequencing, where we sequence all 20,000 genes to see whether there's abnormalities. But in exomes, we only sequence the parts of the gene that make the protein. And then there's whole genome sequencing, where we sequence all the DNA. And that's a very large sort of number of results that we get. Because as you can imagine, I mean, with 23 sets of chromosomes, there's a massive amount of DNA that we can look at. But that's where we're heading. Okay. So when you come for genetic testing, there's 3 options where we can do just a single gene test if we know, like for example, in Huntington's disease, we know what the gene is, so we only look at that one gene. In something like Alzheimer's disease, where we don't know there's a number of genes that can cause Alzheimer's disease, so we do what's called a panel. So the testing looks at the genes, like the 10 genes that we know can cause Alzheimer's. Or ALS is another good example where you do that. And then WES is where we look at all the genes. So I'm not going to go into the details, other than to say that you need somebody that knows how to interpret. And that's the biggest problem that we're running into, is that a lot of people are ordering genetic testing, detailed genetic testing, but unfortunately, the way our system works, there's not a lot of education on how we interpret those results. So the geneticists, of course, are trained on how to interpret results, but a lot of physicians outside of genetics don't always know how to interpret it properly. And so we're working to help with that and to train other physicians. The discussion of the results is very important, whether they're positive, which means that there is a problem, negative, no problems. As I mentioned before, a negative test does not mean that it is not genetic. And then there's 2 things when you see, I don't know how many of you have had genetic testing or have your reports or can look at their reports. There's 2 things to know there that are very important. One of them is if you see the term VUS, on the report, that means that it's a variant of unknown significance. So we do not know whether that change is significant or not, and we cannot make a diagnosis on that basis. And the other is a GUS, which is a gene of unknown significance, where we see a change in the gene, but we don't even know where the gene is or what the gene does. So as you can see, it is quite complicated. The results that we get are quite complicated, and it's not only getting the result, it's knowing how to interpret the result. That's really important. Okay. Next, just want to mention that a diagnosis of a genetic disorder impacts the whole family. And so that's why and it takes sort of understanding. I mean, we appreciate that there's a lot of emotions that goes with getting a positive genetic test. I mean, there may be anger, there may be guilt if your children are at risk, there may be grief. Um, we try to deal with that, and we actually have 4 psychiatrists now that we deal with if people have problems with guilt or depression. You probably, some of you will know Dr. Perez Parada in Edmonton, but we also have 3 other psychiatrists, and I think there's 3 or 4 psychiatrists in Calgary now that can help deal with these issues. It's important to talk about the disorder, what to expect, and then we, of course, always refer to our local, national, international societies, and also work with social work if there is an issue with finances or AISH, for example, things like that. So both in Edmonton and Calgary, we have medical genetics departments, which have a number of not only general medical geneticists, but we have neurogeneticists. So, for example, Dr. Au and Dr. Innes in Calgary, and myself and Dr. Eaton in Edmonton, as well as genetic counselors. And genetic counselors are specialized in doing genetic counseling about a whole variety of genetic disorders. We work with our diagnostic and research labs to make a diagnosis, to make medical recommendations, to provide counseling, and to help with adjustment. So it is, in a sense, like those of you that do go to the clinics at the K or at UCMC, you know that there's, a multidisciplinary environment. And in genetics, we have the same multidisciplinary environment that we work with whenever someone gets diagnosed with a genetic problem or is interested in learning whether they have a genetic disorder. Okay, so let's move on to Parkinson's disease now specifically. So you all know that Parkinson's disease, we don't really know what causes Parkinson's, right? There's been a lot of work on environmental toxins, and I won't go into that, but I think we've had lots of talks on environmental toxins. There's genetic factors, but the biggest risk factor, of course, is aging. And when I was young, we had big discussions about whether Parkinson's was due to genetics or due to environmental toxins. And I remember some of the senior faculty having like big arguments about whether Parkinson's is genetic or environmental. And as you may know, Dr. Kahn, who was in Vancouver, felt that it was due to viruses, and Dr. Duvazan, who was in the States, felt that it was due to genetic factors. And I think it's probably a combination of both. And this is a slide that basically shows you that the younger you are, there's more genetic factors. We think there's probably likelihood that genetic factors play an important part. If you're older and you get Parkinson's, that environmental factors may play an important part. Now, we still don't know. I think the focus is shifting more that there's genetic factors. In the older patients, there are also genetic factors, but they there may be some still environmental factors or other genetic factors that determine whether you will develop Parkinson's or not. So you can see the list on the right here of the different types of environmental factors that are a thing, but still there's a lot of people that are exposed, for example, to pesticides, but don't get Parkinson's disease. But why do the people that are exposed to pesticides get Parkinson's disease? And it may be due to those underlying genetic factors. So this slide is still relevant, although it's an older slide. It is relevant to how we approach Parkinson's disease now. Although, like I said, even in older patients, we're getting a more understanding of what those underlying genetic factors may be. So this is a list of the genetic causes of Parkinsonism. And just remember that there's Parkinsonism, which means that you have symptoms of slowness and stiffness and tremor, but you may not have true Parkinson's disease. And then there's true Parkinson's disease, right? So we use the term So this is a slide of Parkinsonism, which can cause both real, like true Parkinson's disease, but also other symptoms that can other disorders that can mimic Parkinson's. So I'm just going to explain those in a bit more detail. So I think the ones where we have the clearest picture of genetic factors is probably individuals that get symptoms before the age of 50 or even 40. And at least 15% are associated with known genetic factors, but that list is growing as we find more genes that can cause Parkinson's disease. And here I'm talking about true Parkinson's disease, not mimics. And so there's 3 genes that are listed there, Parkin, PINK1, and DJ1, which we find in our patients that are tested that do cause true Parkinson's disease that responds to levodopa. In our population, Parkin or Park2 is the most common. Now, all of these are autosomal recessive. So what that means is that in young onset Parkinson's, usually what we see is that the individual carries 2 genes that are abnormal, for example, in Park2 or Park6. So both genes have to be abnormal. And that each of their parents is a carrier, so they would have one normal gene, one abnormal gene, but they would be fine. They will not develop Parkinson's disease. And of course, those individuals, the parents, would not know they carry this abnormal gene and wouldn't know that they can have a child at risk for Parkinson's disease.
Dr.
So,
Sikorsky, I have a
yes.
question just because the word matches the thing in my question, which says, if a parent is autosomal dominant, can the disease pass to a child of opposite sex, i.e. mother to son, father to daughter?
Yes, yes, but I'm going to talk about dominant next. Let's finish this. Okay, let's talk about recessive. But yes, absolutely, the sex of the person does not matter, and it doesn't matter here either. Okay, so it's not related to whether you're male or female. Whether you're male or female, if you inherit both copies of the abnormal gene in this category, you will have Parkinson's disease. It does not matter whether you're male or female. Okay. And so we're finding in young people with Parkinson's that they will have abnormalities in this group of genes. One thing that's interesting is that these people with what we call young onset Parkinson's they don't look like older people with Parkinson's. They may not have much of a tremor. They also have something called dystonia. And so dystonia refers to usually it's a foot turning in, having an abnormal position and getting cramps, and that's dystonia. And so young people with Parkinson's very often will present with this dystonia, this abnormal posturing of the foot. So unless you know about this group of conditions, a lot of physicians wouldn't think of it as Parkinson's disease. But we know that this is the first sign of Parkinson's disease in some of these young patients. And if they start levodopa, then that foot symptom, the foot dystonia, will disappear, will go away, or it will not disappear, but will get treated just like other symptoms of Parkinson's. And over time, they will develop other symptoms with the slowness and the stiffness and the tremor. So it seems that young onset Parkinson's, and maybe it's just because the brain is younger, do look a bit different. And then, but over time, they will develop the normal features of Parkinson's disease. And they respond to medication just like older patients do. They respond to deep brain stimulation just like older patients do. So the treatment is the same. And in this situation, we can test, for example, if they want, whether their partner is a carrier of the same gene, to whether their children are at risk. So we can do further testing on the partners to determine the risk to their children. So this is autosomal recessive Parkinson's disease. Okay. Now we're going to talk about older patients with Parkinson's. So the typical age of onset, which is 60 or so, a little bit older, a little bit younger. And the main gene that is identified is LRRK2 or Park8. There are now 10 different variants or variants within that gene, 10 different changes in different parts of the DNA that have been found. Now, LRRK2, and again, doesn't matter whether everything I'm talking about does not matter whether you're male or female or whether the affected parent is male or female. Okay. But LRRK2 is one of the genes that I mentioned where there's decreased penetrance. So a parent can carry the gene and not show any symptoms, or maybe show symptoms very late in life, but have a child that has obvious Parkinson's disease. Okay. And this is the most common gene that we find in older onset Parkinson's disease. But of these 10 different variations in the gene, some of them are specific to some ethnic groups. So, for example, we know that there's a fairly high number of people with Parkinson's that come originally from North Africa, and about 1% of them carry the LRRK2 mutation. In some Asian countries, up to 10% can carry problems in the LRRK2 gene. And that's due to founder effect, that in some populations, this mutation or change in the DNA has occurred centuries ago, but then is transmitted within the population. And so that's why some populations have higher numbers of genetic problems than others. So LRRK2 is one that we do test for. I have to say, of our testing, it is rare in our population in Alberta, and we do not find many people with LRRK2. But like I said, in some populations, it's more common. Now, LRRK2 is a dominant. So it means that if an individual has the abnormality in the LRRK2 gene, that each of their children is at 50% risk of having inherited the disorder from them. And the majority will develop Parkinson's disease later in life. Now, with LRRK2, again, these individuals do respond to levodopa. They can have deep brain stimulation. They are treated the same as all our patients with Parkinson's disease. Okay, any questions so far on that? I hope
there's one about the Jewish community. They've heard that there's a higher likelihood of Parkinson's.
Yes, so that is the 1% in North Africa. So
Okay.
that's the Jewish Israeli, like the Jewish community. So
Okay.
and it is we say North Africa now, but it's actually the Ashkenazi Jewish community that has a specific variant in LRRK2. but it's
Okay.
also the Jewish and non-Jewish community that originally came from North Africa that
Okay.
has the same variant. In the Asian countries, the LARC2 variant is different. They have their own specific variant. And then there's a specific variant in Portugal or Spain in the Basque community. So, like the Basque community in Spain has Parkinson's due to LARC2, but they have their own specific variant. The
Okay.
groups of people that arose from North Africa have LARC2, but they have their own specific variant.
Okay.
Okay, the people from Asia have Parkinson's due to LARC2, their own specific variant. So this gene is very an important genetic cause of Parkinson's, and different variants in the gene have arisen in different populations.
So has that changed the percentage? Like once upon a time back in the day, I know when we know more, we do more. It used to be like 5% or 10% of typical Parkinson's would be a genetic component. Has that risen over the years?
Well, it has because we now know more genes.
So would we say it's more than 10% now or not?
Well, it depends on, so those are the rates
Age.
of LARC2 right
Okay.
there. Okay. In young onset Parkinson's, it's 15% right now.
Okay.
I mean, I think as we do exome sequencing and we have better technologies, that's going to increase in young onset Parkinson's, and it probably will increase in older Parkinson's too.
Okay.
I mean, as we find more genes, that number is going to go up.
Go up.
Yeah. Okay. Now, the other thing that we're finding is that there are risk factors. Remember, I said that in older people with Parkinson's, there's a risk factor. So there may be other environmental or other uh, contributions, but there is a risk factor. And so the main risk factor that we know about is called GBA or glucocerebrosidase. Okay. And now we know that this gene has a whole bunch of different variations in different people that have occurred. And up to 15% of people with Parkinson's, and this is older, again, typical Parkinson's disease, that will have a change in their GBA, glucocerebrosidase gene. And so if you have the change, you don't have 100% risk of getting Parkinson's, you have a 30% risk of getting Parkinson's. So that's a risk factor gene. So if you have a problem in this gene, your risk of getting Parkinson's when you get older is 30% higher than the general population. Okay, so this is a risk factor gene. Okay. So we know now the interesting thing is that if you have, so this is inherited, this works as a dominant, but if you have two abnormalities in both of your GBA genes, then you have a recessive disorder called Gaucher's disease, which starts in children, and they have one of these bad neurodegenerative childhood diseases. Okay. So it's the same gene. If you have one gene that's abnormal, one gene that's normal, your risk of Parkinson's goes up by 30%. If both of the GBA genes are abnormal, then it begins in childhood with something called Gaucher's disease, which is we call it a storage disease that causes severe problems in the child. Is that clear?
Yeah, I've
So,
got a question about that. So
yeah,
we've got a person who had done some PD generation testing with Parkinson's Foundation in Phoenix.
right,
Learned they had the GBA variant.
right.
Is it related to the LARC2
No,
or
it's GBA. This is a different
totally
gene.
different? All
Yeah.
right.
Okay. LARC2 is one gene. This is a risk factor gene. The two are
Okay.
not related. If you have LARC2, you have a 90% chance of getting Parkinson's. If you have the GBA gene, you have a 30% chance of getting Parkinson's.
Okay.
But for people who carry the variant in GBA, it is important to tell the family, because if there are other family members or they marry somebody or have children with somebody who is also a carrier, they can have a child with this uh, pediatric onset disorder that causes severe, severe problems.
Okay.
So that's the important thing, is that the gene, when there's one one gene's normal, one gene's abnormal, it just all it does is increase your risk of Parkinson's. If their partner also has this same variant, then they will have a child, 25% risk of having a child with Gaucher's disease. So I think that's why I'm saying, I know people are going to Phoenix, which is great, but how much counseling are they getting compared to what we would provide in our clinic with risks? I mean, was that individual told that there's a risk of Gaucher's disease? I don't know. I'm curious. I'm not,
I don't know
so
if she can hear you. She'll put it in the chat and I'll let you know.
yeah,
Um,
okay.
so do you want me
Um,
to like go in here about that, or are you going to cover it later? Because there are some questions about like, does HS cover it? Where do they go? What do they ask for? You
let,
want to
let
do that
me let
later?
me finish the
Okay.
talk, and then we'll probably have some time. Okay. So if you have the GBA gene, you do have a faster progression of Parkinson's. So I think that's important. And there is an increased risk of getting some memory problems with GBA. So again, needs to be discussed and before you go for testing. So that's why our genetic counselors would always talk to people whether they want to have this information and how much information they want. Okay. Now, there's also some genes that just cause Parkinsonism. So Parkinson's like symptoms, but aren't true Parkinson's. Uh, and now we know that there are 80 different genes now that cause Parkinsonism. So when we do genetic testing for Parkinson's, we actually test for a whole bunch of genes. We test for all 80 genes um, that can cause Parkinsonism, similar symptoms, to get a good picture of what's going on. And even some of the genes that cause Alzheimer's disease can mimic Parkinson's symptoms as well. So, like I said, it's sort of a complex situation that you need. It's good to have a full explanation of what the testing is and what you test for. So, should you have testing and which test is best? Important to talk to your neurologist and to get referred to genetics if there are further questions for counseling. In Alberta, testing can only be ordered by a neurologist or a geneticist. I think just because of what I mentioned, the interpretation, the difficulties with interpretation, we need to figure out which type of test. As you saw, there are a number of different tests, which is best, where to send it. Some people go for private testing to some labs, which don't give as good results as we would give with our testing, but that's, of course, up to you. And information needs to be explained in detail. Now, one reason why you may want testing is potential for treatment, and there are genetic therapies now available. So, for example, I don't know if you know, but ALS actually has a gene therapy now. One type of genetic ALS has gene therapy. Spinal muscular atrophy, another genetic disorder that affects kids, has a genetic therapy. We're doing research for Huntington's disease to find a genetic therapy and another condition that can actually mimic Parkinson's, which is called SCA2. And what this type of gene therapy is, which is happening in a number of places, is that just to show you. So here's DNA, right? DNA makes RNA, and RNA makes protein. And for example, in LRRK2, this protein is causing damage to the cell. So what this type of gene therapy does is we develop a special DNA, or the company develops a special DNA, that that binds to the RNA and destroys it. So the toxic protein, protein that causes toxicity, isn't made. So that's called ASO, or antisense oligonucleotide therapy. And that is a potential treatment for some genetic disorders and possibly uh, the LRRK2 type of Parkinson's disease. So there's a lot of companies, a lot of labs that are working now on different types of gene therapy. Okay. So I'm just going to close by talking about pre-symptomatic or predictive testing. So whether you have, for example, LRRK2 or GBA problem, you can, your children are at 50% risk for having inherited the disorder from you. Okay. In genetics, what we do is we do test adults to see whether they want to know whether they have inherited this disorder, inherited the gene from the parent. It's only done in adults with appropriate counseling and follow-up. And so some people do want to know what their future holds. And so we try to explain all the outcomes, the implications for other family members, confidentiality and privacy. So, for example, this information doesn't go onto our Connect Care, which is our computer system. So we make sure that we deal with confidentiality and privacy if somebody wants genetic testing to know their future. Okay, so in conclusion, I think we're really having an expansion of our ability to make an accurate diagnosis and helps research with potential for treatment. I think education is very important to both physicians and patients, and we find that most physicians in the community may not understand fully, and it is important for patients to understand the benefit and risks of testing. We all work in interdisciplinary environments at the two universities, which is very important. And that in medical genetics, we don't make decisions for you. We just advise you whether or not you want to go ahead with genetic testing. And then I mentioned the issues of confidentiality, privacy, and equality. So I think that this is going to continue to grow, and a year or two from now, if I give this talk again, I expect that it'll be broader and we'll have more genes to talk about, and potentially even some of what's going on in treatment with genetic therapies for some of these disorders. Thank you. Okay, so I think we now have a few minutes for questions.
You got some questions. So there's lots of people asking does genetic testing then potentially help identify Parkinson's symptoms earlier?
It can in the young onset Parkinson's. Like I said, some people if you're 40, people don't think of you as having Parkinson's. And the symptoms may be a bit different than in older patients with Parkinson's. So in that case, yes, I've had situations where I have thought it was something else. I did the genetic testing and it's Parkinson's disease. And then we can refer them to the correct clinic. They respond to levodopa, so they need to be started on levodopa, have appropriate counseling. And then we can also tell the surgeons that they'll still, if they need surgery sometime down the road, that surgery, they'll respond to surgery, etc. So yes, it does help. Not so much in older patients, because I think most of the time we're better at diagnosing Parkinson's in older patients. But in younger patients, it does make a difference. In older patients, I think sometimes because of the research in treatment, genetic therapies for Parkinson's, for example, in the people with GBA, there's cough syrup called Ambroxol that people are studying to see if it slows down progression. So I think it's helpful both for diagnosis sometimes as well as for treatment, as well in particular for research, which I know is what the Gene PD group are collecting DNA samples to do more research on it to find more genes.
Okay. So does having a variant like GBA or whatever impact potential treatment options, DBS or things like that?
Not right now.
Okay.
Not right now.
I'm just going to read this one straight out. Variants of gene ITSN1 is a new discovery in terms of genes which may affect PD. Is that on your
Correct.
radar?
Well, there's lots of genes. I mean, every time you read an article, there are, yes, that gene I do know. I think we have somebody with it, in fact. There's so many genes now, and like I said, genetics is getting very complicated because not only are there more and more genes, what we're also finding is that, for example, in one gene that we know that causes Parkinson's, but there's other genes that can modify it. So what we're also finding is modification genes of the primary genes I showed you. There's modification genes, which is the case again in Huntington's disease as well. So it is, I mean, with genome testing, where people can look at the whole genome on a large population, people with a particular gene, they are finding other genes that can modify it, either in a good way or in a bad way. So it is very complex. It is a very complex system.
So does AHS cover so we need the referral to do genetic testing. Does AHS
Yes,
cover that cost?
absolutely. Everything's completely covered.
Awesome.
It's like
Um,
any other medical procedure and treatment. Yeah, everything's covered. And
if one
yeah.
goes ahead and gets the testing, it is private, like you said, so it can't be used for insurance companies or purposes like that where they won't
So,
be
okay.
refused.
So if you have the condition and you get the testing, that is not private. That goes on to our computer system because you have the disorder.
Right.
Okay.
Okay.
If you want to know whether you have inherited a gene that you'll develop symptoms in the future, that's private. Okay,
Okay.
it's still under Alberta healthcare. We just keep a paper chart and we don't put it onto the computer system. So it's you get the individual gets the result and it's private in that way, but it's still completely covered by
Okay.
Alberta Health.
Sorry.
So it's different whether you have the disorder or you don't have. So predictive testing is private because you don't have the disorder.
Okay.
Now, under Canadian law, no insurance company can ask you for your genetic result if you have it. But they can ask you about a family history or a disorder. I mean, if they ask whether you have Parkinson's disease, you have to tell them whether you have it or not. Or if they ask
Right.
you, do you have a family history of Alzheimer's or Parkinson's? If you do, you have to tell them. So they are allowed to ask family history, but they are not allowed, like whether it's your workplace or insurance, they cannot ask for your genetic result. And they don't have access to it. So if they ask us for medical records, we would not send them the genetic result.
Okay. So is it just a neurologist or can a GP do it? And then there's a second
No,
part.
no, no. GPs cannot do it.
GP
Sorry.
cannot do it. There we go. So,
Family doctors are very restricted in what they can order because,
okay.
like I said, it's so complex. And right now, the family doctors are just not trained. So
Okay.
no family doctor can order genetic testing for Parkinson's or pretty much almost anything. Like almost
Okay.
all the tests, no matter what the disorder is, has to go through a specialist.
Okay. And then is there criteria? For example, my grandma had it and my aunt had it, or can you just say this is what I would like?
Well, we get the referral and then we would assess it, evaluate it. So the genetic counselor and I usually look at the referral and say, yes, we can do testing. No, we don't think that they'll be testing. The best thing is if one of the relatives so for example, if your aunt had genetic testing and we know the gene, then absolutely we'll do the testing.
Okay.
If you don't have symptoms and don't have a test, it's so again, the best thing is to get a referral, we'll assess it, and then we'll get back to you with whether we can do testing or not. But we try to be as sort of flexible and do as much testing as we can for individuals that want it.
So there's a lot of questions in the chat and coming in from the
Mhm.
viewing parties that how do you know? Should we go do it? Should we make our kids do it or should we encourage our kids to
Yeah.
do it? Like It's big and it's broad for sure, and
Yeah.
there's no one right answer, but
Yeah.
what would you say?
So I can tell you both in Edmonton and Calgary, we work closely with the movement. It's like genetics and movement disorders works closely together. So, I mean, if I'm in clinic, Dr. Yen or Dr. Shetty or whoever will come and say, what do you think? What should we do or what test should we order? And it's the same in Calgary, I know, with Dr. Sarna and Dr. Au. Um, so talk to the neurologist, and even the community neurologists are also very good at getting a hold of me if they have a question or if you have a question. So ask your neurologist. And then, like I said, we're a small group. There's a small group of us in Alberta. So we're happy to talk to each other and try to give you some advice. But like I said, sometimes the family doctor can send in a referral and then we can deal with it directly as well.
And then I've got, you covered it, I think, a little bit for the one kind. So is there a definitive difference between genetic Parkinson's and non-genetic
No,
Parkinson's as the disease progresses? No?
no, no, there isn't.
Okay. Well, thank you everybody for your questions. Thank you so much, Dr. Sikorsky, for talking about a topic that's on a lot of people's minds, families. I know we had a lot of adult children who joined us today for this, so thank you.
Okay, thanks. My pleasure. Thanks for inviting me. Nice to see you, Brandy, and I'm sorry I can't see
See you
everyone
too.
else. Thank you.
All right.
Bye-bye.
Bye-bye.